Welcome to the InTouch Health Webinar Series. This is Scott Young, and I'll be your host for this webinar. Today, we'll be featuring speakers from Northwestern University and Hamilton Health Hub as they detail their programs with on-site employer clinics. Today's webinar is brought to you by InTouch Health, the platform which will virtualize healthcare from the inside of the health system out. Dr. Cullen, Medical Director of Corporate Health Services at Northwestern University, has been working in occupational medicine as a provider since 1999 and Medical Director since 2007. She rejoined Northwestern Medicine in 2010 and has been involved in the integration of 9 additional hospitals. She is also actively involved in workforce health and safety policies, including hazardous drug and telehealth. Dr. Bernstein, Medical Director of Telehealth and Professor of Neurology at Northwestern University, studied at Cornell with postgraduate training at Mount Sinai Hospital, Illinois, New York Presbyterian Hospital, and the University of California, San Francisco. He specializes in neurovascular critical care, stroke, stroke of unknown cause, stroke in young people, acute stroke therapy, atrial fibrillation, and stem cell therapy for stroke. Adrian Trömel is VP of Strategy at Hamilton Health Hub, where he works to bring innovation to the healthcare market. He has experience in angel investing, strategic consulting, and medical device innovation, having worked with companies of varying sizes in life sciences and healthcare. Dr. Hamilton is a board-certified emergency physician, native West Texan, and CEO and founder of Hamilton Health Hub. He is an experienced investor, executive, and consultant for early-stage companies, as well as larger private sector firms. He has a range of experience, including years of work as a practicing physician, several private equity deals, and multiple successful JV relationships with some of the biggest healthcare systems across the U.S. Our webinar will begin shortly, but first, a few notices. You have all been auto-muted, but if not, please make sure to mute yourself. During the webinar, you will be able to enter questions in the questions widget located on your audience console. Questions will be answered at the conclusion of the presentation, so please feel free to ask your questions at any point throughout the webinar. If a fuller answer is needed or you run out of time, questions will be answered later via email. This webinar will be recorded, and a copy of the recording will be available on our website and sent to registrants. This webinar presentation should last about 60 minutes, including time for questions and answers. Moderating today's webinar is James Wright, Vice President, Network Partners at InTouch Health, and now I'd like to turn it over to James.
Thank you, Scott. We are very excited to host this webinar on one of the most important trends in healthcare today, the rise of self-insured employers and developing on-site employer clinics. I'll just say a few words of background to set the stage for what we'll hear from our presenters. Over 150 million Americans receive health insurance benefits from their employers in the U.S. Employers have seen their insurance premiums rise year over year, and an increasing number have turned to a self-insured model to take control of these costs. As a self-insured employer, the employer is now the payer, and they are looking for ways to decrease the cost of care while also providing an excellent healthcare benefit for their employees. This is where the on-site employer clinic fits perfectly. And with telehealth, these clinics can be very cost-effective and scalable. We are delighted today to have 2 different perspectives, both with direct experience in the employer clinic model. First, we'll hear from Drs. Cullen and Bernstein from Northwestern Medicine. With over 130 locations, they are the 6th largest employer in the Chicago area. They have implemented on-site telehealth clinics for their own employees. Next, we'll hear from Dr. Toby Hamilton and his colleague, Adrian Trömel. Their company, Hamilton Health Hub, is implementing and operating on-site telehealth employer clinics for smaller employers, ranging from 300 to 2,500 employees, by far the lion's share of companies in the U.S. Both have some compelling experience and data to share, and at this time, I'd like to welcome Drs. Cullen and Bernstein to share their experience.
Thank you very much. This is Richard Bernstein. I'm very grateful to our partners at InTouch for giving us the chance to share some of our experience. I'm going to let Dr. Cullen talk about our particular corporate health offering, since it's her brainchild and she's really brought it to fruition. But first, I thought we would share just a little bit about our health system overall, so that you can all know the context in which Dr. Cullen is doing her great work. If we could go to the next slide, please. Next slide, please. And I can do it now. Good. So we, as you heard, are on the larger side when it comes to healthcare delivery systems. We have more than almost 30,000 employees. We are a comprehensive stroke center, a comprehensive cancer center. We are proud to be ranked #1 in Chicago by U.S. News, and many of our academic programs are ranked in the top 10 by U.S. News, and we are about a $6 billion system. We span in really all directions except east, where it's just water. We span the entire Chicagoland area, and our system is anchored by two large referral centers. One is downtown Chicago, Northwestern Memorial, and the other is Centre DuPage Hospital further out west, which is a large community-based referral center. Plus, we have about 8 other hospitals around the region and over 100 outpatient centers and ambulatory and urgent care centers where Northwestern medicine physicians and employees work. Here are some of the members of our system. I already mentioned our downtown hub, Northwestern Memorial, and our western hub, Centre DuPage. We have Delnor Hospital, Lake Forest Hospital, and McHenry Hospital, among others, as well as all those clinics. And all of these hospitals provide care appropriate for their size. Northwestern Memorial and Centre DuPage are tertiary care. They do advanced heart and neurosurgery and neuroimaging. The other hospitals are more community hospitals, but we view us all as an integrated system. And one of the goals of telehealth for us is to assure that a patient, or in this case, an employee who needs care at any one of our system hospitals, will get the same care and draw on the same large bank of expertise as someone who shows up to one of our tertiary care hospitals. Here at Northwestern, telehealth lives in our Department of Innovation. Innovation is really the intersection of people, process, and technology, and you all know that telehealth is very much a people and process-driven entity. And the technology, especially when we partner with people like InTouch, is usually for us doctors the easy part. People spend a lot of time thinking about technology, but if the technology works, you shouldn't have to think about it at all. And that's been our experience using some of the InTouch devices that you'll hear about from Dr. Cullen. This is a menu of some of the things that we're offering in telehealth. Probably for historical reasons, neurology is very active in telehealth with both a large telestroke program, a tele-neuro ICU program, and a number of subspecialty outpatient programs. We do some ophthalmological studies remotely, especially for diabetic retinopathy, and our sleep providers do CPAP adjustments and circadian rhythm disorders remotely as well on an outpatient basis. With that as background, let me turn it over to my colleague, Dr. Cullen, who can describe the extremely exciting work she's doing in our employee health program. Dr. Cullen?
Thank you, and thank you to InTouch also for inviting us. My name is Jane Cullen. I'm the Medical Director of Corporate Health Services for the system of Northwestern. Corporate Health Services is really our occupational health services, as others might know these services. Again, we serve about 30,000 employees, but again, about half that amount again in contractors, volunteers, other people who enter the system. We also serve the employees of some and others of our 2 campus partner hospitals, so it's about another 10,000 additional people, and then the university there. And finally, we have the typical other occupational health business, such as hotels and factories, etc. We were asked by InTouch to kind of outline the need for our telehealth program and touch on its implementation, and that's what I'm hoping to do today. Can I do my slide here? Oh, okay. So our mission at Northwestern is, both patient safety and also employee safety and health. In order to take care of our employees, I think I'm too far ahead here. Can we go back? Can you take me to I seem to be going in the wrong direction. There we go. Thank you. In order to take care of our employees, we want to provide them with kind of the right care at the right time and from Northwestern's point of view, at the right cost. We wanted to have timely access to employee health and return people to work efficiently. 5 years ago, Northwestern was one hospital in Chicago, and now, as we've said, we're 10 hospitals across the region, 2 medical groups. And as we merged, we wanted to standardize care for our employees also, and telehealth has allowed us to do this across our regions and connect our employees with the health care that they need. Telehealth cuts through geography, and as you've seen from the map, it's helped us connect all these sites that are remote from Central, for instance, which is our downtown campus. As we merged and looked at all these places, we analyzed how employees obtained care or an approval to return to work. Some of them had to wait for an appointment with a provider. Others just decided not to wait and would end up in our busy emergency departments or in our immediate care centers. Telehealth has allowed us to address these challenges by decreasing the time they spend waiting to have an appointment, decreasing the times they go to the ER, decreasing, the time away from work, decreasing OSHA recordables because we're in control of their restrictions and their time away. It increases their provider availability, that someone's around there and able to talk to them through the telehealth, and in that way has increased engagement and satisfaction from our employees. It also has expedited the return to work and with thoughtful restrictions for that particular job. Let's go to the next slide here. As I said, it allowed us to provide more timely care. The other issue that we met was that as we had this rapid growth at Northwestern, we had different staffing across the regions. There'd be a nurse at one, there'd be 2 providers at another. What kind of care were we providing at each of those sites? So as we tried to merge ourselves together, telehealth allowed us to connect all those sites with a full-time provider. Some sites were so low in volume that it was hard to justify a full-time provider there, and so telehealth also provided us with ability to take care of people. How we did it is many different events. If we focus on the left side of the slide, the first decision is, where is our physical space? And what we decided to do was start with our pre-existing corporate health clinic space. And within that space, we took the injury room and made that also the telehealth room. So if a provider was in the clinic, they would be seen in that room. If the provider was not at that clinic that day, they would telehealth into the monitors that were in that physical space. We also needed a space that was for the provider conducting the telehealth visit because we need to do it in a private way. While we had the equipment, we still needed the privacy to do that. Now that's kind of morphed along the way. My first telehealth visit was done at my house through my phone, which we'll talk about, against a wall, blank wall in my house. But most of the time, these providers are in their clinics, but providing care to another clinic. As far as technology, on the patient's end, there's a camera, which is the InTouch camera. It's very sophisticated, can zoom and move all around. It can zoom in so that I can see someone's nail or the bottom of their eyes and the redness in their eyes. It can move around the room from left to right and up and down, so we can focus down on their foot or we can watch them bend. So it's allowed us to zoom in. This technology also allows us to use and portray somebody's x-rays up on the screen that they're looking at so they can see their broken bone or an image of a rash that they might want to understand what that rash might be. As I said, the TV is the part on the patient's end. There's a TV on the wall. They're looking at myself, at the provider on that TV, and any images that I might put on, such as an x-ray. I must say, as a comment, we started with a rather large TV, so I portray quite large on the TV itself, so we've managed to decrease the size of TVs that we're using. As far as we continue with technology, in some places we actually don't have the room for a TV and a camera. You know, as we've gone along, we've realized that it needs about 9 feet to really zoom down on and see everybody from top to bottom. So in some areas, we're much smaller than that. In a couple of our remote locations, we're using iPads. We're still using InTouch, but we're using iPads. Obviously, we use the Zoom part of that, but for most of our functions as a healthcare system, employee health, you know, with back injuries and return to works, we usually can manage with the iPads. Our plan is to replace the iPads with the camera or TV combination once we're in a better space. Also in the future, we're planning to add a stethoscope function, which can be plugged in so that we can listen to people's lungs at those remote sites. On the provider end, you use either our laptop, our computer, our own iPad, our phone, all have the apps so that we can access the various locations where the patient or the employee might be. We have headphones that we use for privacy as far as technology. We've needed IT support both from InTouch and from Northwestern. We've had such things. We've needed Wi-Fi boosts for some of the hospitals where we were getting some difficulty seeing particularly through the iPads themselves. As far as operations on the right-hand side of the slide, several events happened there too. We had to sit down and develop a schematic to outline the workflow that would be involved just in a healthcare visit. You know, how are they going to be scheduled? How does the call center offer it as an option to the person? Who's checking them in and consenting them, rooming them? The provider's in another location, so we had to notify the provider to then come into the room through the telehealth monitor once they were all set. How do they receive their follow-up papers and make appointments? We had to determine how many visits a day would be a reasonable amount for a provider staffing another clinic. And initially we kept them low, and now it's just whatever's open can be filled by an in-clinic visit or a telehealth visit. Compliance helped us develop an all-in-one consent to include telehealth care. We determined how much time it would take to do a return to work or a recheck, about 15 minutes in the end after we were comfortable. And then we kept the new injuries around 30 minutes, which is exactly the same as we would do for an in-clinic visit. We also addressed provider comfort during telemedicine. You know, we doctors are used to touching people and examining people, and so none of these providers had done telehealth. But and when we started, we used the clinics where there was a nurse or another clinician to help us. I think we're getting more and more comfortable. We actually sometimes use the patient to kind of say where they're hurt, you know, test where they're hurting. But we can see people bend and move. We can see their eyes without having an actual hands-on and becoming much more comfortable. What we did at Northwestern, because we have actually essentially 3 providers covering 9 hospitals, we spread the providers out on their weekly in-clinic places so that there would be a provider in each of those clinics sometime during the week. So if you weren't so comfortable and you wanted to see them fairly soon, within a day or 2, you could schedule them from an in-person visit a couple of days later. And that seems to make both the employee and the provider comfortable. As far as the EMR, we currently document it as a telehealth visit in our EMR. We're currently working on a new version of the consent, or not the version of consent, but how it can be submitted to us so that the person can fill out a consent. And that's done, and we don't necessarily need someone in the corporate health clinic to help us consent them and sign them in. Training of the staff and physicians was fairly easy. For staff, it's really about the care of the equipment, turning it on, turning it off. We've elected actually to leave the cameras on all the time in our clinics, and they're in secured spaces. The providers had InTouch training centers, sessions and practice scenarios with InTouch. And then we did mock scenarios within corporate health. We decided to start with types of visits as initial injury visits, new injury visits. We get a lot of backs and splashes and return to works, as you'll see. We see rechecks that might have gone to the emergency room, such as wounds and burns and musculoskeletal. And we can do mass exposures, such as pertussis and meningococcal vaccine, meningococcal exposures where we might prescribe medication. We bill essentially the same, you know, physical is remote, but it's still performed, so we continue to bill that way. Going on to my next slide. How does it work? So as I kind of touched on earlier, the appointment's made in advance, so someone might just walk in and want to see the provider. The person checks into the clinic. The nurse or the clinician might take vitals as appropriate, and then they text or page the provider to enter into the room through the TV. The provider does their normal visit as they would at any other in-clinic visit. Again, we offer the services that's shown on the left-hand side. We have the live sites set there. We actually can add Valley West, as I can see on the left side now, is a live site just about 2 weeks ago. As far as appointments to date, this shows our metrics from September 1st of last year to essentially September 1st of this year. We actually kind of were very, very slow for the first 4 months. We were kind of building and getting our processes going. So we've increased our number of visits over the last several months. We have almost 300 return to works, as you can see. During that time, 33 injuries and 43 rechecks. You can see the hospitals that take most advantage of those. I would say we're just on this gradual incline and of people coming to visit us for this as they learn about it. We have not socialized this. We'll tell you about it in a second. That's in our future state. So results are that the response of employees and staff is that the younger folks took it in stride more than the older. I think everybody now is feeling much more comfortable, both on the provider side and the employee side. We have much increased engagement and satisfaction that they can walk in and there's a provider available either in clinic or remotely, so they are able to get taken care of then. So it's a quicker turnaround for the patients themselves, and the staff's extremely comfortable with the process now. Our future enhancements, we would like to add, we have out-of-town onboarding, so rather than seeing in the clinics, we can actually talk to the person who may actually never come to Chicago to work on site. We have some people who never end up in Chicago, but we can also do some onboarding that way. We can talk to our employees who are also undergoing any kind of needle stick or splash from a blood or body fluid exposures, rather than always electronically. What we'd like to add is an employee app where they would have the ability to do visits from home. So we could do the return to work. You're coming back the next day, we can connect with you so you don't even actually have to come into corporate health. And the final thing we'd like to work on is this employee marketing campaign, now that we feel that we are comfortable with the process, and we'd like to actually advertise that this is something that employees can use for their care, whether it be return to work or injuries or rechecks. So that summarizes Northwestern's corporate health experience with InTouch. Thank you.
Great. Thank you, Dr. Cullen and Dr. Bernstein, for that detail and sharing your experience. I want to just remind everyone that if there are any questions, please use the little questions widget that you'll see on the webinar. And we'll address questions at the end once we finish both presentations. So at this time, I'd like to turn the time over to Dr. Toby Hamilton and his colleague, Adrian Trömel, to talk about Hamilton Health Hub and the impact of microclinics at employer work sites.
Thank you, James. And Thank you, Dr. Cullen and Bernstein. That was a very interesting presentation. And as said, we will now actually be looking at what Hamilton Health Hub does. This is Adrian Trömel speaking. And what we do is we really provide microclinics for the smaller self-insured employers. So what we're looking at here is really the employers with work sites as small as 200, 250. You're going to see a case study with a work site of about 300 employees. And we're looking at really addressing that unaddressed section of the market, really leveraging InTouch's telemedicine technologies. So to kick it off, there we go. This presentation will really just give you an overview of the problem that we're also familiar with rising costs of healthcare, especially as a self-insured employer. And then really dive into the case study of one of our sites here in Houston. And then we'll go over the results of that and see what's next. So as you all know, as a self-insured employer, especially, healthcare costs are rising. The Kaiser Family Foundation study, you might have seen overall family coverage premiums increased by over 54% in the past decade. This far outstrips anything from general inflation to wage increases over the same period. And over time, this is becoming an unsustainable position, both for employers and for employees. Again, also as providers, you'll also be familiar with the fact that most of the healthcare spend comes from a very, very small section of the population. In terms of the average employer group, 5%, typically your chronics, are those who spend over 50% of the healthcare costs. And then to really complete the Pareto principle, we get the last 15% getting that last 30% of the spend. And then overall, for the employers specifically, we're fortunate here working in healthcare that we may have a bit more understanding. But even then, there's very little insight into where that money is going, how that money is spent. There are always anecdotes that we get from our clients here that they'll get the annual or quarterly reports from their brokers, from their third-party administrators, and be able to do absolutely nothing about that. So these are frustrating stacks of documents that they get, and all they can do is say okay and put them aside. And it's really those three things that we hope to address with the help of InTouch's telemedicine solutions. All right, come on. There we go. So overall today, really, for the employer and the employee, the care continuum is a long and convoluted process. Everything from for any point of touch with anything to do with healthcare, already taking a long time. If an employer needs pre-employment drug testing, can often take days, and that in turn is money to the employer. And then as we know, there's a very low percentage of the actual adult population who gets their physicals, although there are studies out there showing just how valuable they actually are. And then even of those who know the care they need, there's an over 60% non-adherence rate for chronic treatments and for the fulfilling of the prescriptions that they get. And then further driving up the cost to those employers, there's a significant portion of out-of-network care. And then overall, that just means that for every visit that people even still do, and that employees still do end up going to, there are over 3 lost productive hours for the employee and for the employer. Which is why what we seek to do is to make care convenient and accessible for the employee and the employer. What that means is that on site, we really do a full analysis and patient stratification of the employees at our employer work sites, and then we provide everything that we can relating to primary care and anything on site related to healthcare. What that means is, we'll, if necessary and requested by our clients, we provide the on-site drug screenings and the pre-employment physicals. Especially with the case study you'll see, we're looking at a meat processing plant where, of course, Turnover is high, and that means that they need to hire also very quickly, which means that saving those days from getting the drug screening results is invaluable to them. And then once, of course, that those employees are onboarded and they stay, we're providing the full continuum of primary care, including the physicals, primary and acute care on site, chronic care management programs, basic urgent and emergent care, and then, of course, continuous drug testing, seasonal care. The other thing that we have started doing is also, as we further continue working with the third-party administrators at the worksite of the employer, is that we can then help them manage the claims and further drive in-network usage too. So there we go. What that means is that we've really defined what we like to call the microclinic. It's really the worksite clinic that is built for access and convenience for the smaller employers with less than about 1,500 employees, and really allows us to manage that one captive audience that are the employees and their dependents. Because what it turns out is that there are a slew of on-site providers already out there and operators. We can think of the Premise Healths and the Care ATCs, the Marathon Healths of this world. But the average employer that's going to be looking at those is probably going to have 2,500 or more employees, and the minimum site that they'll consider if you ask them for will be about 1,000 to 2,500. What that means is that we really target those much smaller employer work sites. So what that looks like is that we can then, rather than providing only a near-site solution or a part-time solution, we can really provide a full-time on-site clinic for the smaller self-insured employer. What we do, and the way we can do that, is by using a team of healthcare professionals that really use operational efficiency and all of the technologies that InTouch provides us to be able to provide care in the most accessible and convenient form possible across the care continuum, including chronic, primary, and urgent care. So let's dive into that case study. What we have here is a self-insured employer. As you can see, it's actually a picture from their worksite in the background, and they're a meat processing facility. You have about 300 employees at the worksite, with just a couple more on the plan, of which 220 employees on that plan. What we've seen after or rolling out that clinic, we really got a room in the back of that clinic that gave access to all of the employees on site, and we managed to build out space with InTouch technology, establishing the ability for the insured and covered employees to get fully covered care there with no co-pays. And we're allowed to establish direct cash pay rates for the non-covered employees by then directly negotiating with other vendors, such as the drug testing, the lab and imaging services, and other medical supplies. We could then provide the care that the employer had been seeking outside at significantly lower rates. And what that really allowed us to do was to really onboard and educate and show the employee population what all of these technologies were, and really engage them and drive up that engagement through, first of all, onboarding physicals. We can then increase every point of touch, continuing to engage that population through pre-employment, through every touch point, including the drug testing and every primary, urgent, and acute visit that we get. That includes even 24/7 availability as our providers remain on call to this population. So then, looking into those results, what we've seen is that in a 4-month period between May and August of this year, that we've seen an over $100,000 drop in the total medical expense of this company. For a company that spends nearly $2 million per year on medical expenses, $100,000 in a 4-month drop really goes directly to their bottom line. In turn, this even equates to about 71 per member per month reduction and savings, a reduction in overall spend. Separate from this, what we can really break out are the direct savings that we can provide through the more convenient, accessible, and lower cost of care that we provide. So what that means is that really although we saw an increase in utilization, and we're about to see an example of that, because the cost of care that we provide is lower than what used to be provided outside of our clinics off-site, we know that overall we provided over $120,000 in short-term savings also directly to that employer. And the interesting thing is we really did see an increase in overall utilization. What we can see was that there was in this case, this means there are also long-term savings because more people were getting access to the care because more convenient and more accessible on site. Rather than having to take 3-4 hours out of their work, they were able to come in their lunch break and get that primary care. So we saw an over 38% increase in annual physicals. And in those, we found 34 uncontrolled conditions, including diabetics and hypertensives, and 2 coronary artery disease cases that had both over 90% occlusion. What this really means is that although these individuals were then an increased spend, being then immediately sent to the cardiologist to get stented, this means that a significantly more expensive episode was prevented and potentially a life saved. So overall, that means that the accessibility and convenience and affordability really created short and long-term value for the employer and the employees. We saw an increase in utilization, meaning more people were getting care. And this increased utilization really allowed for the early and ongoing disease management. And then also we saw a decrease in total emergency room and urgent care visits. We have a selection of anecdotes from our providers who every time they would pick up the phone would be able to direct the care of the employees as they come in and really be able to avoid the expensive emergency room visit for that employer, be able to provide care on the phone or meet them at the worksite. And what this really communicates to the employees from their employer is that the employer cares. We've had comments from the employees that really also communicate, in addition to the increased healthcare benefits, that this has been a significant cultural change. And what we hope to see, and we're collecting that data right now, is also a decrease in turnover with those patients or with those employees. So how do we do this? At this one site, we have a console from InTouch that you see here on the left, because we were provided a dedicated room. For some of the open workspaces that we're in discussions for, we're also considering the kiosks that you can see here on the right with the same abilities as the console. So that means fully connected primary care equipment, including your blood pressure monitor, pulse ox, stethoscope, dermatoscope, and the like. And what that allows us to do is really adapt to the different needs of the employers. So then how does the employer benefit? That means that our team of providers really serves as the shepherd, and we can help that employer tell their employees that they care about them, show their employees that they care about them. By managing the claims and managing this population, we can help drive down costs short and long term by avoiding expensive episodes of care. Working now with the third-party administrators and the brokers, we can help design the benefits to be able to drive increased utilization also on-site, meaning that employees get more accessible care and also avoid more expensive points of care. And then overall, we've seen a decrease in the cost of insurance with our employers. One thing that wasn't listed there was that also stop loss insurance is often dropped or reduced. The premiums are reduced when an on-site clinic is present at the self-insured employer. So that means we really provide two types of return, the return on investment and the value on investment. Return on investment are the hard dollars that you see from increased in-network usage, long-term savings from preventative care, decreased emergency room and urgent care visits, and decreased sick days and decreased time off work. But then the value really are what one might call the softer things. Things such as increased retention, increased productivity, decreased turnover, and an overall change in the work culture to one of a culture of care. So as said, the team really is composed of a slew of a collection of people with significant experience in the healthcare space, including as executives in large healthcare systems, providers, and on the plan side. And so that was where we are with Hamilton Health Hub, and that's how we use InTouch technologies to really provide accessible and convenient care to the self-insured employer.
Great, thank you so much for the presentations, Adrian and Dr. Cullen and Dr. Bernstein. I know Dr. Hamilton is there also. We wanted to field a few questions now. A number of things have come in. So I'd like to address those. And let me just first just drill into the response from the patients, first of all. So Dr. Cullen, you mentioned that the mix of users was maybe a little bit on the younger side. And Adrian, you were mentioning that it seemed like there was good reaction across the board. If maybe you could both address the response to the patients. Did they how did they feel about these on-site clinics? Was there any hesitation? If so, how might those be mitigated? Just some experience from the patient's point of view would be helpful. And Dr. Cullen, I'll ask you to go first.
So I would say that at first, I think people didn't really understand what we were doing because it was brand new and we hadn't really advertised it. When I referred to the younger workforce, I think they just were more used to being on social media and computers and so on and so forth, whereas the older workforce like myself, hadn't grown up with that. But as time has gone on and the comfort level of the staff and of the provider, it's a very accepted and they feel like they're given care, that they have access to one of our providers, when they're in any clinic across Northwestern, and the same level of care, standardization of care that would be provided, at any other location.
Thanks. Were there any, it's a change in behavior for people to go to an on-site clinic. They're used to just maybe going to the ER or going somewhere else. Did you have to do anything to sort of encourage them, remind them, to get them to use the clinics, the on-site clinics?
We had on-site clinics already. That's where we had put, so most of our experience for this year has been in sites where we already traditionally might have had a provider or some kind of clinician in those clinics. We've had changes across as we've merged hospitals and we've had changes on where they go for those that help. And that has been the messaging to go into one of the clinics already open. What we will now embark on is going to a place where the clinic may not be open 5 days a week or 7 days a week, but that you can now go in and there's a camera in the room and you're really by yourself. And that's, before we start that, we want to message to people a little bit more about what our program is. But those that have come to the clinic for rechecks find it very convenient and quite enjoy the visit. So that's been our experience.
Thank you. Dr. Hamilton or Mr. Trömel, would you please maybe address the same?
Yeah, I would say that our patient population is designated. So we're not out in the community digging up patients. These are 300 employees, and that is our population and no one else, at least in regards to this site. And as a result, we kind of have got what we've got. We've seen that the younger people are a little more responsive, but as part of our program, we do bring them in, we give them a physical, and then we show them the technology. And that's when we get sort of the wow factor, and that is, oh, this is really cool. I can see my own eardrum for the first time in my life, right? I can see my throat on the screen for the first time. And that tends to get them sort of excited and engaged. And I think it makes some of the older population more comfortable with the notion that they're going to be seeing the doctor through the screen moving forward, that the tools are still there, and they're seeing the same things. So the response that we've gotten has thus far been extremely positive. I will say that the technology does provide a point of connection between the patient and the physician and its team. So it's been positive, that's for sure.
Great. Another question came in about who, and this might vary between Northwestern and Hamilton, but who are the ones that are connecting in to see the patients? Are these doctors that are part of the Northwestern team, for example, or are they outside contractors? And then also in the Hamilton case, who is the doctor that connects in? And while we're on that topic, maybe you could also address who is on site at the clinic. I mean, what kind of staff do you need there with the technology, with the patient, to facilitate this? And what kind of training does that person have? Dr. Cullen.
So from our point of view, we have, as I said, one central location and 9 others. We have corporate health physicians. They're Northwestern medicine physicians as part of corporate health who will see during their workday either an in-clinic person at the clinic they're at or a telehealth person at another clinic that doesn't have a provider on site that day. Those are the people that are staffing, and really we have 3 people covering 9 locations at this point. And then as far as when we started our telehealth, we used those sites where there are clinics. So at each hospital, there's a clinic. And at those sites, varying by day, but most of the time there's a nurse there. There may or may not be like a medical assistant or a front desk person. We have this kind of combination depending on the site that you're at. And those people can, for instance, have them sign the consent and room them in and do vitals as needed. And that's traditionally what we've had over the last year. And really it's the same flow as an in-clinic. You're just leaving them or helping as the provider comes through the camera. What we want to expand to is, we have some sites where we have a hospital with, 20 beds. And so if we have a camera there for the employees, we don't necessarily have a nurse there 5 to 7 days a week. So we are moving to the point of, okay, we still want to care and reach and connect with you. So how do we arrange for who's going to open the room, and how do they sign the consent so that they can have the same level of visit that the larger hospitals have because there's somebody there at all times. I hope that answered your question.
Great, thanks. Dr. Hamilton?
Yeah, we've got our docs. We are evolving into having that central location for our physicians. But today, we're having our docs either work from home or from the clinic that they normally worked at, and they're just kind of getting our patients in between their cases. Most of the cases are relatively minor in nature. They're follow-up for chronic care, or they are, a sinusitis. And I think the data shows pretty clearly that most of the cases are relatively minor. We are centralizing those people moving forward, but today we're letting them answer it from home.
And on site there with the patients, what kind of staff do you have there facilitating in the clinic itself?
Yeah, we're using a technician that we've trained specifically to do the activities that we think need to be done at that site. At the end of the day, we're looking to provide care at the lowest possible cost, and in many cases that means delivering it with a lower priced labor model. And so we've got a technician that we train specifically to suit our needs. They're checking out to and answering to the physician in regards to any movements or choices that they're making. And so we felt really comfortable with this so far. So we're basically doing our own internal specialized training program with a medical technician. The last thing that I'll add about that component is that the market that we're targeting tends to be the smaller self-insured employer, say from 250 employees to about 1,000. That's where we think there's a niche in the market. And that's where we think that the decrease in labor prices make that model viable. Once you get above, say, 1,500 employees, it's easier to deliver the services because you've got economies of scale and the cost is spread out amongst more employees. When you're using, when you only have a handful of employees that you're treating, you've got to be very, very sensitive to any changes in pricing, and thus we've sort of dropped down the labor cost to about as low as I think it can possibly go.
Yeah. Along those lines, a question came in, and Dr. Cullen, this might be a good one for you. And what's the cost savings approximately between a traditional clinic and a telehealth clinic? And have you been able to sort of quantify that in your model?
I'm not sure we've actually put the numbers together at this point. I mean, some of the cost saving goes into ensuring that they don't go to the emergency room or the ICCs. It's also, this is all work-related injuries that we're taking care of. We're not taking care of wellness at this point. And obviously, you're saving on having a provider in 10 different locations. So I don't have the numbers for you, I'm afraid, on that at this point.
Yeah. Dr. Hamilton and Adrian, have you looked at that? I mean, I know you're implementing telehealth clinics, but as you looked at kind of a provider on-site model versus the telehealth model, how have you thought about the economics there?
We fundamentally have the belief that the patients are going to struggle without some form of human touch, and that's why we've got the technician there. We've seen a lot of data around uptake being fairly low without a human there. So lots of times people are sick, they want to be touched, they want to know somebody's listening to their heart, etc. And so we are providing that labor. But if you were to compare our costs versus what it costs to run a comparable clinic with a staff of a physician and nurse and front office, we're probably about 25% of that cost is what I would say. Because again, any doctor's office is going to require the doctor, at least one nurse, and at least one front office person, and in most cases, it's going to be much more than that. And we're doing it with the doc and a technician covering that entire site. So yeah, we're probably 25% or less.
Right. Another question came in for an unscheduled visit. A patient, an employee just walks into the clinic. What's the average wait time that they're seeing to see somebody? And Dr. Hamilton, if you want to answer that. And
so again, we're a little bit different in that we only have those 300 employees. So right. Today we're not having any wait time. But I'll say with 300 employees, we expect the number of visits per day to hover somewhere around 2.5 to 3.5 patients per day. So there's a lot of downtime. When somebody walks up, they can get seen essentially immediately, unless one of those scheduled visits is taking place. And even then, we can probably see you within about 10 or 15 minutes. So today, we're not having any issues with wait time whatsoever. Just completely not an issue today for this entity.
Dr. Cullen, anything on wait
I
time?
would kind of echo this. Yeah, I would say we really don't have any wait times either. You know, we have 3 providers, and probably the longest anybody would wait is 15 minutes, but most of it's just a matter of we're seeing which provider has an open slot at that point, and connecting to that person. So again, just like Adrian, there's not an issue.
A question came in for the Hamilton group. How do you address employees who want to retain their privacy and therefore not seek care at the employer's site?
That's I think that's one of the big issues to overcome. So we make clear to them that it's 100% confidential. Any information or care that we provide, it's the same as going to your primary care doctor. That data is not available, nor is it shared with the employer. To do so would be unethical and illegal. So anything that we do is done completely and totally with a Chinese wall between us and the employer. So that is an issue that we have to address, and we do in fact have to win the trust of those employees as we're going through it. And the only way that we're going to do that is by providing a consistently good product and them beginning to feel trust that, hey, we're not there to weed out sicker people and get them terminated. We're there to weed out sicker people and get them healthier. And I think when people start to see the results of that, we've already got a pretty significant engagement percentage, but we feel like that we can win their trust with time through the results-based, just through sharing their results. But it definitely is a major concern to overcome inside of a company.
We're kind of wrapping down to the end here, but I just wanted to ask a final question that's kind of come up is, how are employers positioning this to their employees from a benefit standpoint? Is this kind of a soft benefit? Is it a hard benefit? Is it really impactful to the patients, or is it just sort of a minor convenience? I mean, how have you seen the employers positioning it, and what do the employees see in terms of a hard or soft benefit? Toby, I'll ask you if you could go first, and then Dr. Cullen can
Yeah, for us, this is wrapped into part of their formal benefits package. And how the company is positioning it is, at least for us, that we have free care available to you, 40 plus hours a week, plus somebody's on call 24/7. So the company has positioned it as an attempt to keep their workers healthy, that employees that work healthy work harder, more effectively, et cetera. So that's what we're doing today is we've positioned it along with the employer as a service that they're paying for free in order to keep those employees healthy. And we're seeing a lot of benefits from that positioning. The employees were excited about having those types of services there. And what we've said to them in no uncertain terms is the simple answer that we all need, and that is that we all don't take care of ourselves, frankly, the way that we need to. I'm sure everybody on this line misses appointments and doesn't follow up and get their physicals, et cetera. And now we've put this primary care clinic, urgent care clinic on site so that there's really no excuse. You can stop by for 15 minutes when your shift is over. We can draw some blood and get a quick appointment done. So we're here to take care of them.
Thanks, Dr. Cullen. Any final wrap up here? We're just about out of time, but I wanted to just give you the floor at the end.
No, and I think we haven't actually totally advertised our program. But, you know, I think that people who find that it's available, we're saying that this is all a part of, you know, their employee health and safety and ultimately patient health and safety. And I think we want to standardize, you know, the same across all of our locations for whoever comes to see us in corporate health. So I think that's the messaging that everybody's getting, and along with more availability of a provider at any time during the corporate health hours.
Great, thank you so much, and thank you all, Dr. Hamilton, Mr. Trömel, Dr. Cullen, Dr. Bernstein. We really appreciate your time and all that you shared. I'll turn the time over back to Scott to just to wrap up. Again, thank you so much for your time and sharing your findings.
Yes, thank you again to our presenters and for our audience members for joining today's presentation. To repeat, that a recording of this presentation will be shared with everyone who registered in 48 hours following this presentation. Also, for additional questions or information, please feel free to contact us at the email address on the screen, which is feedback@intouchhealth.com. And you can also visit our website to find a recording of this webinar or for upcoming and past webinars that you can view on demand, and that will be at intouchhealth.com/learn. So thank you, everybody, for joining, and have a good rest of your day.
Thank you.
You.
Thank you.